Alrighty, so I'm going to be doing one of my case studies primarily on hepatopulmonary syndrome. Um, so, firstly, I learned quite a bit about pulmonary hypertension and hepatopulmonary syndrome. As far as portal pulmonary hypertension, there needs to be uh, a mean pulmonary artery pressure over 25 millimeters mercury at rest or above 30 with exercise. There also needs to be increased pulmonary vascular resistance or PVR and a PCWP that's lower than 15 millimeters of mercury. Um, there's also mild, which is between 25 and 34. Moderate would be 35, 44, and then severe would be considered over 45 millimeters of mercury. Pulmonary hypertension in the presence of portal hypertension with or without cirrhosis isn't really understood and is independent of the cause of portal hypertension. Your systemic circulation with higher cardiac output and lower SVR happens in about half of patients with end-stage liver disease. High cardiac output can cause pulmonary artery shear forces that cause endothelial cell proliferation and increase smooth muscle cells in the vessel wall. Vasoconstrictor substances like endothelial 1, endothelial levels are higher in patients with advanced liver disease, and the presence of portosystemic shunts might increase the quantity of endothelium reaching the lung. And for hepatopulmonary syndrome, increased endogenous nitric oxide, or NO, is the key primary factor for making pulmonary vascular dilatation. Respiratory therapists would know this very well because we actually give inhaled nitric oxide. Um, so although NO levels in the exhaled air of patients with hepatopulmonary syndrome are increased, consistent with pulmonary overproduction normalization has been noticed after liver transplantation. And some studies say that endothelium 1 and tumor necrosis factor alpha may also involved in pulmonary microvascular tone modulation, and some of the contributing factors to the pulmonary vascular dilatation or angiogenesis, vascular remodeling, pulmonary AV shunts, and portopulmonary venous anastomosis. Pulmonary vascular dilatation also allows for quick passage of the mixed venous blood into the pulmonary veins. And the fault in oxygenation is because of a VQ mismatch that increases the blood flow and preserved alveolar ventilation during the inhibited hypoxic vasoconstriction. So calculation of the AA oxygen tension difference about 15 or greater than 20 millimeters mercury for patients above 64 years old. It's a very sensitive index of early arterial deoxygenation in hepatopulmonary syndrome, because this difference can actually increase before arterial oxygen tension becomes very low. And the diffusing capacity of the lung for carbon monoxide is often lower because the alveolar capillary interface is too wide to really let for complete equilibration of carbon monoxide with hemoglobin. Now that I kind of just mentioned a few things, I'm going to be going over a case report. So, pretty much a 52-year-old female with chronic liver disease with portal hypertension for the past 2 years presented with dyspnea on exertion for the past 1 month, which increases during exertion, also in the upright position or posture. She also had a history of abdominal pain and black colored stools for the past 4 days. And during her physical exam, the patient had grade 3 pan-digital clubbing and central cyanosis. Her vitals were normal except sats were 86% in the lying posture and became 80% when she was standing up after about 3 minutes. On abdominal examination, spleen was palpable 4 centimeters below left costal margin. Her cardiovascular, respiratory, and central nervous system were found to be normal. Lab results showed RBS of around 89 with normal blood urea and creatinine. A liver function test showed SGOT 38, SGPT of 40, ALP of 45, bilirubin of 0.8, PT, platelets 15, INR of 1.4, total protein of 4.5, and albumin of 2.1. And that's about it, I think. And then the complete hemogram showed high hemoglobin of around 16.8% with a total count of 3,000 cells and a platelet count of 30,000 cells, and then peripheral smear. The red blood cells looked normochromic, normocytic. White blood cell count and platelet count were diminished. Viral serologic markers were negative, and seroplasm was 19.3%. ABG showed lower PO2, more than 5 millimeters of mercury from supine to upright posture, indicating that opening of the intrapulmonary shunting during upright posture, resulting in arterial hypoxemia. Ultrasound abdomen showed liver span of 10.7 with dilated portal vein, and spleen was enlarged up to 15.9. Collaterals were noted in the epigastrum. The chest x-ray showed reticulonodular pattern or bilateral basal zones. HRCT of thorax showed bilateral patchy ground glass opacities in the dependent position. Endoscopy showed small grade 1 varices and gastropathy with normal duodenum. Echo showed ejection fraction of around 60% with normal left ventricular systolic function, and then it proceeded with contrast echo with agitated ceiling, which showed bubble appearance in the left atrium and left ventricle after third cardiac cycle, which kind of tells us of a right to left intrapulmonary shunting. CT pulmonary angiography was normal. She was managed with nasal, oxygen, diuretics, laxative, proliphatic antibiotics, and beta blockers and nitrate to reduce portal hypertension. She was given 1 unit of whole blood transfusion. Her blood counts improved, but her SpO2 remained the same. Hence, she was prepared for liver transplant. However, she was not really willing for a transplant and was pretty managed conservatively. As far as hepatopulmonary syndrome, it's really defined as a triad of liver disease, pulmonary gas exchange abnormalities leading to arterial deoxygenation, evidence of intrapulmonary vascular dilatations. The criteria really consist of presence of liver disease or portal hypertension, an elevated room air alveolar arterial oxygen gradient, 15 millimeter of mercury, or if they're above 65 years old, it'll be 20 millimeters of mercury. Evidence of intrapulmonary vascular dilatations in the basal parts of the lungs, and absence of other significant cardiopulmonary disease. And this patient had all 4 criteria. So the hepatopulmonary syndrome is really significant complication of the chronic liver disease, especially with cirrhosis with portal hypertension. However, there are case reports of patients presenting with hepatopulmonary syndrome due to non-cirrhotic portal hypertension because of inherited thrombophilisis. Prevalence of hepatopulmonary syndrome among patients with chronic liver diseases range from 4 to 32%. Upregulation of the endothelial nitric oxide synthase in the intralobular pulmonary arteries and enhanced enos-derived NO production were associated with the development of hepatopulmonary syndrome. The enhanced enos-derived NO production may have resulted from pulmonary endothelial B receptor overexpression and increased circulating endothelial 1, induced vasodilation. The precise trigger for these events remains unclear, but one possibility is that nitric oxide production is stimulated by absorbed endotoxin, which is less efficiently cleared due to portal systemic shunting and lower reticuloendothelial cell function in cirrhosis. Hypoxemia, platypnea, and orthoxia are the other characteristic findings that we see in hepatopulmonary syndrome, like we see in this case right here. Intrapulmonary vascular dilatations may have been identified by contrast enhanced echo, macro aggregated albumin scanning, and pulmonary arteriography. Contrast enhanced echo is generally preferred because it's more sensitive than macro aggregated albumin and less invasive than pulmonary arteriography. Contrast echo is performed by injecting a contrast material, usually agitated saline, and then performing echo under normal circumstances. The contrast opacifications only the right heart chambers because it's filtered by the pulmonary capillary bed. But the contrast may opacify the left heart chambers, and if a right to left intracardiac intrapulmonary shunting is present within intracardiac shunt, the contrast appears in the left heart with 3 heartbeats after injection. But with an intrapulmonary shunt, contrast generally appears in the left heart 3 to 6 heartbeats before its appearance in the right heart, as in our case. And the pulmonary arteriography is really generally reserved for excluding alternative causes of hypoxemia. pulmonary hypertension and large direct AV communications. So 3 angiographic patterns were described. Type 1 minimal pattern, which characterized by normal to finely diffuse spidery abnormalities associated with severe hypoxemia, orthodoxia, and a good response to 100% inspired O2. Type 1 minimal pattern may evolve into a type 1 advanced pattern, which characterized by diffuse, spongy, or blotchy angiographic appearance. It is less responsive to 100% inspired oxygen. Type 2 discrete pattern was characterized by local AV communications associated with poor response to the supplemental O2. Prognosis is poor with developmental with hepatopulmonary syndrome. One study that I saw reported higher mortality in patients with hepatopulmonary syndrome compared with the control group, and the long-term supplemental O2 is the most frequently recommended therapy for symptoms obviously related to hypoxemia. As far as transjugular intrahepatic portosystemic shunt placement, it's a medical intervention that's been associated with improvement of hepatopulmonary syndrome in a lot of different cases. At present, the most effective and only radical treatment is liver transplant, but it's indicated for patients with incapacitating hypoxemia due to the hepatopulmonary syndrome. And there's been a few studies that I read that showed lower shunting with a striking improvement in oxygenation following the liver transplant in some patients. And additionally, observational studies have found that among patients with and without hepatopulmonary syndrome, their survival is similar in both groups after liver transplant. And these observations led to symptoms of hepatopulmonary syndrome as an indication to liver transplantation. And cirrhotic patients who are on the waiting list for liver transplant have a shorter survival period if they develop hepatopulmonary syndrome. So it's suggested that all cirrhotic cases should be followed closely for the syndrome and should have priority in the waiting list. So overall, hepatopulmonary syndrome is a significant complication of cirrhosis, which causes dyspnea and cyanosis in patients with liver cirrhosis. There's no relation between the development of hepatopulmonary syndrome and the severity of cirrhosis. In contrast, enhanced echo is simply the most sensitive way to demonstrate intrapulmonary shunting, so thereby confirming the diagnosis of hepatopulmonary syndrome. And here we had a 52-year-old female with chronic liver disease with portal hypertension. She showed symptoms of dyspnea, platypnea, melena, cyanosis, clubbing, and orthoxia. And she had an esophageal varices and splenomegaly, which means indicating the portal hypertension. Her ABG showed hypoxemia and orthodoxia, and from this investigation, she was diagnosed with hepatopulmonary syndrome. And she was managed conservatively, as she was not willing for a liver transplant. And here are my references.